Okay, so welcome everyone. It's my pleasure to be here today with you, and hopefully we are going to have a very successful meeting over those 3 days. My talk today is about the dysmorphophobia and its impact in cosmetic dermatology. I think this is a very important topic. We are facing those patients almost on daily basis, so it's very important to be able to spot those patients and deal with them in the right way. So in order to go for the dysmorphophobia, it's very important to realize the goal of cosmetic procedures. Patient satisfaction is achieved not only from good aesthetic results, but also by meeting patients' psychological goals. Some psychological conditions, behavioral patterns, or life situations predispose to dissatisfaction of the outcome, even if we did a great technical job. So it is not only what we do technically, it is also how the patient is feeling about that. So why psychological factors should be considered? Because patients look for more than improvement of the physical appearance. Patients coming to us in order to improve acne scars or treat melasma or decrease the wrinkles, it is not only the appearance. They want to feel better. They want to feel that they are having a better look. So it's about feeling. Screening out patients who shouldn't have procedures can prevent frustration. Combined psychological technique with cosmetic procedure could help. Why patients look for cosmetic procedures? Either they have external motivation, and this is interpersonal agendas, comments from other people around, or sometimes social agendas. And here I would like to emphasize that social agendas today are having a very significant impact. Many people are coming to me because they feel that they want to have a good look like this blogger or this actor or this colleague or whatever. So we have a very strong pressure from the society to have Botox, to have more full lips, to have certain things which does not belong to the person himself or herself. So this is the social agendas. In many cases, when we are looking at the actresses, we don't realize that they have a lot of makeup and certain illumination and lightening. That's why they have this perfect looking skin, but this is not the case. If we see them without those effects, without the filters, without the makeup, it is a completely different story. So those are the external motivation. There is internal motivation, like long-standing feelings about deficiencies and strong commitment to change. The third group is psychological disorders, which also can push sometimes people to go and ask for cosmetic procedures. What are those psychological disorders? The depression, if the patients are depressed or narcissistic or perfectionist or patients with dysmorphophobia. Those are psychological disorders which are pushing people to seek cosmetic procedures. The body dysmorphic disorder, this is the distorted body image, which is the person's mental or inner picture of his or her outward appearance, including size, shape, and form. So the patients, when they look at the mirror, they are going to see things which are not existing. A lady like this looking in the mirror and she's seeing that she's fat, although this is not a reality. This is not the situation. This is not the case. So dysmorphophobic symptoms in a dermatological setting have been termed dermatological hypochondriasis, and in individuals without apparent cutaneous lesions, the condition is termed dermatologic non-disease. And this is a case of dysmorphobia. So this is a girl called Rachel. This is what we are seeing. But when she looks at the mirror, this is what she's seeing. So we can see that she's seeing something which is totally not true, which is not existing. She's not happy because when she looks at the mirror, this is the image she's seeing, which is not there in reality. Regarding the frequency, always we depend on the statistics coming from the United States. And they said that as much as 1% of the population may have dysmorphophobia. This is a huge number, by the way. one study demonstrated that the prevalence of body dysmorphic disorder appears to be significantly higher among people receiving dermatological care. And it was found that around 15% of patients come to dermatological clinic, they have dysmorphophobia. This is a lot. And there was two publications in 2003 and in 2002 addressing the body dysmorphic disorder, and they found that up to 15% of patients seeking cosmetic surgery will have clinically significant body dysmorphic disorder. And the problem with those patients is that they rarely seek psychiatric treatment because they believe that their problem, perceived physical defect, is at the heart of their torture and problems. However, the big problem is that the surgery or the cosmetic procedure will never help. Actually, in many cases, it exacerbates the problem. So it exaggerates the problem. And this is something we have to keep in mind. This is an example of a model who was looking like that before doing anything. And then she underwent 10 different cosmetic and surgical procedures. And then she was looking like that. Is she looking better? I doubt. Did she need those procedures? I don't think so. However, this is what she went through in order to feel better. And always she was not satisfied because what was normal didn't satisfy her. So if we change that normal to something else, definitely she's not going to be satisfied. So regarding the morbidity, people with dysmorphophobia frequently develop major depressive episodes and are at risk for suicide to that extent. They also may exhibit violent behavior toward their treatment provider. So we are at risk. We have to be careful. They may believe firmly that a marked change in their perceived body defect is a prerequisite to their happiness and well-being. And let me stop here for a minute, because those are two important things. Two questions I would strongly recommend every colleague to ask the patient during the interview process. One, how do you feel about this problem? If the patient is telling you that this problem is the main problem of my life, and if it is resolved, then everything is going to be okay in my life, this is a red lamp you have to be careful with. The second thing, you have to ask your patient, how long do you spend thinking about your problem every day? How long do you spend thinking about your problem every day? And if the answer is 1 hour or more, most probably this is dysmorphophobia. So the time the patients are spending to think about this problem is very significant. If it is more than 1 hour, this is another important alarm. Regarding the male to female ratio, it is equal. There is no more males or more females. The onset of dysmorphobia usually occurs at the teenage years. However, average age in people receiving dermatological care is 33.7 years. Any body part can be a source of distress. However, the body areas noted most frequently are the skin, hair, nose. Complaints vary widely, including preoccupation with wrinkles, spots, acne, and large pores. So sometimes those are problems they come with. So they come to tell you, do you see my wrinkles? It is really annoying me. It is the biggest problem in my life. And then when we examine them, there are no wrinkles. Or the same for large pores or acne. There is no acne. And those are very common problems. Vascular markings, greasiness, scars, paleness, redness, excessive hairiness, and thinning of hair also are encountered commonly as complaints they come with. Folliculitis and scarring may be a product of skin picking and plucking of non-existing hairs. These often result in exacerbation of distress. So sometimes you can have those patients with dermatitis artifacta or some irritation of the skin because they feel or they think that there are some hairs ingrown under the skin. So they try to pick that hair, and this will lead to inflammation and post-inflammatory hyperpigmentation. So this is something also which presents frequently. My advice to my colleagues is that if you have a patient like that, and she's coming to complain of her nose, and she doesn't like her nose, and she wants to have a nose job done. She wants fillers or Botox or surgery, rhinoplasty for her nose. Would you touch her? We have to ask ourselves, is there a problem to be resolved? If there is no problem, don't touch. Just do for her anything which is letting her feel that you are doing something, but don't touch her nose. Do microdermabrasion, do some maybe mild peeling, something to show her that you are doing something, but don't touch her nose from the physical point of view. The therapeutic challenges are the fact that they request help late, they keep the distress secret, they resist the psychological types of therapy, and this is the most important thing, they worsen after the procedure, whether it's dermatological, surgical, or dental. What is the management of the body dysmorphic disorder? There are medications, psychotherapy, medications and psychotherapy, combination of both, alternative therapy, and from my point of view, the most important is avoidance of procedure. We have to have a way to spot them and avoiding doing a procedure which is going to change the tissue. It's okay to do for them something like microdermabrasion, something like a mild peel, something like non-ablative rejuvenation with the laser. It's okay to do something like that, but don't do something which is going to change the structure or the appearance of the tissue, because they are going to be more distressed. Prevention of body dysmorphic disorder, challenging media's unrealistic image of attractive people. And I think today, this is one of the most important things. The media is driving people crazy. Everyone is thinking that they should have smooth skin like this actor or that actress or whatever, but they don't know that those people, they have the worst possible skin you can imagine without makeup and without lightening. We see their skin beautiful because it is under the special effects of filters, of lightening, of makeup. But without those effects, their skin is really damaged. So it's very important to let people understand the reality that their skin in many cases is much better, in fact, than all those people in the media and social media and so on. Educate parents, teachers, primary healthcare professionals, and adults dealing with young people regarding pitfalls of the perfect look. We don't have to have a perfect lip or a perfect, I don't know, cheek or whatever. We need to keep our shapes natural as much as possible, and everyone is created in a certain shape which is the best for him or her. This is something which should be taught to the parents and in the for the teachers and the media as well. Self-education and raising awareness about symptoms and warning signs in dress and behavior. There are some medico-legal pitfalls as well. So failure to recognize the disorder, since people with dysmorphobia may blame the physician for producing what is perceived as an unacceptable outcome. If you treated someone like the patient who had perfect nose, and then she's not happy with the outcome, of course she's not going to be happy with the outcome. She had a perfect nose and she was not satisfied. So if you are doing something and changing that, most probably she's not going to be satisfied. And at that time, who is going to be blamed? It is the physician who did that change. Failure to combine aesthetic treatment with psychiatric therapy when treating a person with dysmorphobia also is putting a lot of responsibility on the practitioner. Does cosmetic procedure produce psychological benefits? Yes, it can improve the self-esteem, it can improve the body image, and it can improve the quality of life. No, if the patient is depressed, if the patient is having an anxiety, if we are causing depersonalization, if you are changing the face as Dr. Lim presented in the previous talk. If we are changing the shape and then the patient is looking at the mirror and he is not able to recognize himself or herself, this is the depersonalization and it causes a lot of negative effects. Keys of success: proper patient selection becomes even more important to the entire procedure process. Good candidates hope to boost their self-image and their self-esteem. Dermatologists and cosmetic surgeons should attempt to distinguish patients as emotionally appropriate or inappropriate. How to select the patient? There are 4 important steps: the general demeanor, the motive, diagnostic indicators, and accurate assessment techniques. The general demeanor, it's the physician's first impression. Is the patient dressed provocative and alluring? Is there something wrong with how the patient is dressed? Does the patient retreat from physical contact or actively avoid eye contact? Those are alarming signs. How is the patient's affect or mood? Is he depressed? Is he agitated? This is important to answer. Is the voice monotone or easily excitable? In this case, this is an anxiety. So we shouldn't do something for patients who are depressed or having an anxiety. Then the motive, we move to the motive. There are some questions to assess the motivation, and it should be open-ended questions, like how long have you wanted this change? Direct questions like why do you want this done? And important questions, do you think this surgery will make any other thing different or better for your life? If they say that this is going to solve all my problems I have in my life, this is an alarming signal. And also we need to ask them, does anyone else want you to have this surgery? It's important to understand the motive of the patient. It's important also to understand the patient's current life situation, marital status, work type, and job satisfaction. Impressions based on demeanor and personality cannot guarantee proper patient selection. Information obtained from expressed internal motives and initial impressions may make some unsuitable patients appear to be appropriate candidates for the surgery. Then we go to the diagnostic indications. So study of the patient's history and sufficient time with the patient should expose several diagnostic indicators useful for classifying the patients into. They might be positive diagnostic indicators or poor diagnostic indicators. What are the positive diagnostic indicators? An actual disfigurement is clearly noticeable to both the patient and the physician. The disfigurement is minor and corrective cosmetic procedures has been planned for a long time. Occupational appearance is important. If an air crew who would like to have a perfect look, this is one they stand. So the occupation is very important. And also emotionally stable patient is aging and wants to look younger. What are the poor diagnostic indicators? History of repetitive psychiatric illnesses or medications, patients having life crisis, unhappy patients, body dysmorphic disorders. Also patients who have multiple cosmetic surgeries and are dissatisfied each time. Patients who believe that the correction of the surgical defect is the solution to all their problems. If patients are having unrealistic expectations, this is a problem. And if we have a patient like this who thinks that if we do some procedures, then this is going to have this outlook, of course, this is very unrealistic. Patients with package of pictures who are having many photos with detailed marking and either unrealistic or need to know what cosmetic procedures can be done. Surgeon shopping, if the patient is coming and she have visited before our clinic, all the clinics in the city, then we have an issue. Finally, we go to the accurate assessment technique, where we need to answer those questions. Why specifically does the patient want? Why does the patient want that performed? Why does the patient want this procedure performed now? And why choosing that particular doctor? And then we go to the interview process, identification of unrealistic expectations, discuss the most appropriate way to achieve the required goal, explain benefits and side effects. Patient must be led to mutual contract of responsibility, and finally, presence of spouse or parent is advisable. And then we have to have a patient education, before and after treatment photos of similar conditions, video demonstration, pre and post operative information sheet, and finally we give them information brochure and verbal instructions, and we give them some we ask them to get some questions and we answer their questions. Then we have the step technique where we need to identify the stresses, the target, the envision, and be proactive. So identify the patient stressor, specify their importance, see the stressor and make sure they are realistic. And finally, ensure you have tools for dealing with them up to the patient's expectations. Target. Let the patient target the area needed for the correction. Ensure the goals are realistic and attainable. Limit your focus on one target at a time. Envision. Ask the patient to envision how their perception, emotions, life would be different, and does it sound fantasies or realistic, and can you deliver that? We have to be proactive. If clear, attainable goals and realistic expectations are present, be proactive and advise the treatment plan for patients. It's contraindicated if the patients are having self-mutilation, major depression, agitated, suicidal thoughts, or psychotics. Ideal patients are having no obvious psychopathology, well-defined areas of dissatisfaction, they have realistic expectations, and has internal motivation. So in conclusion, it's very important to, for every cosmetic dermatologist to develop screening method to review clients for emotional and psychological stability. Formal psychological evaluation is reserved for psychotic or emotionally unstable patients. And at the end, we don't want to create people who are looking unnatural or having worse image than before. And those are two important books which we can read for more details about dysmorphophobia. Thank you very much for your attention.
Если это мотивация, то это реалистично, все хорошо тянет. Ну, в заключение, каждый дерматолог и косметолог должен обязательно оценивать эмоциональное состояние, проводить собственно